On behalf of myself, the co-chairs, Professor McAlinden, Dr Lamb, we'd like to welcome you to the final session of today, which I think everyone will agree has been a really, really interesting day. And the title of this session is Hot Off the Press. So first of all, I'd like to welcome Dr Jess Dyson, who is a consultant hepatologist working at the Freeman Hospital in Newcastle. So Jess specialises in transplant hepatology and autoimmune liver disease, and she has co-authored on guidelines including the PBC guidelines, and today she's going to give us an update on primary biliary cholangitis. So thanks, Jess, over to you.
Thank you very much for inviting me to speak. We were talking about these sessions last night at dinner, and hopefully 13 minutes, I've hopefully risen to the challenge. What somebody said I should point out the name of PBC, so I will do. It's now primary biliary cholangitis, and it used to be cirrhosis. It's been changed because most people don't have cirrhosis, and had lots of practical implications for patients, and in terms of just things like insurance premiums. So the C is no longer cirrhosis. So goals of therapy in PBC are twofold. Firstly, to reduce the risk to life and need for transplantation, and by that we want to use disease-modifying therapy. And then secondly, to improve quality of life and functional status of patients, and in thinking about that in terms of symptomatic treatment. One of the things I want to say is about how we recognise the high-risk patient. PBC has a traditional feeling of, ladies in 70s and 80s, nobody ever came to harm from PBC. I'm not sure that is true, and the data certainly doesn't suggest that's true. Young people do badly. So if you're diagnosed under the age of 45, you have a higher risk of needing a transplant or dying from your disease. People are often very symptomatic, mostly itch, but often, many of you who look after PBC patients will hear about fatigue as being and cognitive symptoms. Men do worse, partly due to a delay in diagnosis because PBC is such a predominantly female disease, but being male is in itself an independent risk factor. And clearly, if you have advanced disease, synthetic dysfunction, either histologically or FibroScan evidence of advanced disease, that's a poor predictor of outcome. And then there are disease variants, and I think even in the time I've been kind of running our clinic in Newcastle, I'm learning all the time about the different kind of phenotypes of disease. So ductopenic variants, so these are often the people who are very itchy and certainly have more aggressive disease. And then the hepatitic kind of inflammatory disease, much commoner in the younger people, quite difficult to differentiate potentially from a true overlap syndrome with autoimmune hepatitis, but the hepatitic inflammatory patients do badly and are much more likely to come to transplant sooner. And just thinking about, let's do simple things well. So ursodeoxycholic acid, first-line therapy, everyone should get it unless they're intolerant. And I would urge you to remember the therapeutic dose is 13 to 15 milligrams per kilogram per day. Urso is a good drug, it's a safe drug, and any urso is better than no urso, but you do need to give a therapeutic dose partly because it does good things in terms of your outcome, but also, unless you're on a therapeutic dose, you are not eligible for some of the second-line therapies, which we'll touch on in a second. Delay in starting treatment with urso is harmful, and it's usually tolerated quite well. Some people get GI side effects, some people get weight gain and hair loss are the other things that patients describe. And thinking about response, so increasingly there's an understanding that people who are an incomplete responder to therapy with urso, again, do badly, and biochemical response is the major predictor of long-term outcomes. There were lots of different response criteria, Barcelona, Paris 1, Paris 2. It doesn't matter which one you use. It's all a bit confusing. I wouldn't get too bogged down in it, but broadly speaking, an alkaline phosphatase of about 200 is where we define incomplete response at the moment. The POISE criteria, or Toronto, are pretty simple. So alk phos greater than 1.67 times the upper limit of normal. So that is an incomplete responder to therapy, and you need to be thinking about adding in extra treatments. And actually, increasingly, we've got data to suggest that anything but normal leaves you at increased risk of doing badly. That probably makes sense. And I think within the next few years, we'll start seeing normal LFTs being the aim of treatment, and that'll make it even less confusing. They're either normal or they're not. So second-line therapies, what are the options? I would urge, again, to remember that these are add-in therapies. Patients should always continue on urso, because actually it will be doing something, it's just not quite enough. And certainly when I started using obeticholic acid, I wasn't very good at pointing out that this was an additional therapy, and people stopped their urso and got a terrible rebound in their liver blood tests. So they're add-in therapies. And in terms of our options, at the moment we have 2 options available on the NHS. So firstly, obeticholic acid. So that's an FXR agonist, randomized controlled trial data, placebo-controlled biochemical improvement as compared to placebo. It protects your hepatocytes from toxic bile acids and also stimulates choleresis. The problem is itch in some people, and certainly when I started using obeticholic acid, we didn't have a very good mechanism for treating itch. I can treat itch easily enough in some people, but we need to know they're itchy in order to treat it. And actually we ended up stopping treatment on quite a few people. And the thing that's really revolutionized our management of itch with obeticholic acid is we now have an autoimmune nurse specialist who intensively contacts the patients. We titrate their itch therapy, and that's meant our tolerance of obeticholic acid is much higher now. It is a dose-dependent itch problem. And as I said, you have to have been on a therapeutic dose of urso for a year or more in order to be eligible. So actually, if you come to me not on the right dose, then I can't give you obeticholic acid. So it's really important that we optimize therapy. Start 5 milligrams, assess at 6 months, and again, the licensing is for the POISE criteria, POISE being the trial, the RCT. And bezafibrate's the alternative. Now, obeticholic acid is licensed for PBC. Bezafibrate is not, so it's being used off-label. Have to hold my hand up. I'm a big fibrate fan. Sounds like I'm an alcoholic. I'm a big fan of fibrates. It's a PPAR agonist, receptor agonist, anti-cholestatic, importantly also antipruritic. So in contrast to OCA, where we get itch, actually Bezel is good for itch. Again, randomized controlled trial, both of these published in the New England Journal, showed biochemical improvement and also improvement in liver stiffness. Modified release tablets, just 400 milligrams a day. In terms of risks, however, bezafibrate does come, or fenofibrate, both come with risks. Small risk of acute liver injury and also kidney problems. You potentially can use fibrates if people have renal impairment, but you may need to dose adjust. You may need to avoid the modified release preparation. And as I say, I'm a big fan of a fibrate, but we do see problems with liver injury. I've not seen somebody whose liver injury has failed to resolve. I've not had anybody go into acute liver failure, but you do need to keep an eye and stop it if you have problems. And what about the real world? Well, trials are all well and good, aren't they? But actually, this is UK PBC data, so some of you may well contribute to the data collection across the country. Left hand alkaline phosphatase, right hand ALT. And across the top, you can see obeticholic acid. Well, actually, if your blue bars are normalization of blood tests, obeticholic acid really, in the real world, is not doing a very good job at normalizing alkaline phosphatase, in contrast to bezafibrate, which has about a 50% ability to normalize your liver blood, your alk phos. But you see almost the opposite picture when you think about ALT. So transaminitis is actually much improved with obeticholic acid versus a fibrate. And I think that's helpful potentially in terms of who we should give which second-line therapy to. So my young, aggressive, hepatitic, inflammatory patients, I would go straight for OCA because it will improve their ALT. And then just triple therapy. So I've got 70 patients on obeticholic acid now. And actually, increasingly, I've now got people on triple therapy as well, and this data would support that. There are still a small proportion of people, despite obeticholic acid and urso, don't normalise, or despite Bezel and urso, and you can use all 3 together and you improve biochemistry, so we are doing that more and more. But second-line therapies aren't the answer to all our problems, so we do have to be cautious in cirrhosis. The FDA, so the American Safety Organization, issued a warning a few months ago now stipulating that OCA is contraindicated in advanced disease due to the risk of acute on chronic liver failure, decompensation, and death. You can still, according to American rules, you can still use it in Child-Pugh-A disease as long as they don't have portal hypertension with just the same dose, 5 milligrams daily, but you do need to keep a close eye. There's also a risk of decompensating chronic liver disease with a fibrate, and certainly I wouldn't use them in people who are jaundiced. That graph there is from a Toronto group paper. And actually, if you start with a high bilirubin, you're at increased risk of decompensating. And also remember, there may be a drug-induced liver injury rather than decompensating of their cirrhosis. Keep a close eye. What does that mean? Well, right, I'm not saying this is right or wrong. I do fortnightly bloods for 2 months for anybody I'm giving a fibrate or rifampicin to, and then 3 monthly thereafter. And I would urge you, if you're thinking second-line therapies, you should also be thinking about the transplant question. Certainly in cirrhotic patients, these people ideally should all be going to a specialist centre, or at least being discussed with a specialist centre. You can only access obeticholic acid with a hub-and-spoke NHS England mandated MDT approach anyway. But I think we should always be second-line therapies, and would we transplant if we needed to? And there's a more nuanced question about, well, actually, are we risking missing the opportunity to transplant somebody? I can give you obeticholic acid, slow down your disease trajectory by a few years potentially, but are you then going to be outside the window where you would be transplantable? So I may do you no favours by giving you OCA, and actually a transplant would be a better treatment for you ultimately. And this, again, is UK PBC data provided by Dave Jones and George Mells. Are we doing well in terms of, are we giving Bezel Fibre and obeticholic acid appropriately? And the quick answer is no, not really. Less than half of people who are incomplete responders are getting referred and discussed in MDTs. And actually, you are 6 times as likely not to be getting second-line therapy as you are to have failed to respond to therapy. There's a long way to go. And a word about transplant and PBC. So, I mean, the clue is in the name. It's primarily a biliary disease. So actually, as soon as you're getting hepatocyte dysfunction, that's an alarm feature. So if your clotting's abnormal. And I would urge you to remember that falling albumin and rising bilirubin are particularly concerning in cholestatic liver diseases. So the same is true of PSC. What we tend to see in the cholestatic disease is that we potter along, and then suddenly everything falls apart. But certainly by the time your bilirubin is approaching 100, your average survival is less than 2 years. There is a significant rate of disease recurrence in the graft, so about 30%. But recent data from global PBC group quite convincingly shows that ERSO reduces post-transplant recurrence, so we would leave all patients on it, provided they tolerate it. And the indications for transplant are the same as for all etiologies. In this country, we use UCALD, so score greater than or equal to 49. However, we also transplant for intractable itch. So you don't have to be cirrhotic. If you have itch that does not respond to any of our available therapies, you can transplant for that indication alone. We've done somebody relatively recently, and it is quite dramatic. Wake up post-transplant and the itch is gone completely. And that graph here is just from the European Liver Transplant Registry data. And just to demonstrate that actually over the last couple of decades, despite us having better treatments, actually the absolute number of liver transplants that we do for PBC is not really significantly dropping. I'm doing quite all right for time, I'm quite proud of myself. So itch. I find itch, I think we should be more aggressive with itch. People who come to the clinic and no one's ever treated their itch, and it sounds like a really boring symptom, but actually it properly wrecks people's lives. And I mean, as demonstrated by the fact we take it seriously enough to transplant for it. Start safe, start easy, go bile salt sequestrant, so Questran or colesevelam if they can't tolerate Questran because it is pretty manky. Rifampicin is the next drug, good evidence base, clearly an anti-tuberculous antibiotic traditionally. Best evidence base, but actually again it has risks. There is a small risk of acute liver injury. Again, I would do fortnightly bloods for 2 months. Start low, titrate up to a maximum of 600 milligrams daily. There are then other treatment options, all of which have a much less good evidence base because actually our understanding of the pathophysiology of itch is relatively limited. Gabapentin, naltrexone, sertraline, that is the kind of traditional itch ladder. I tend to use them in a slightly different order, kind of depending on the patient in front of me. And light therapy, again, can be very effective for patients. And just a note about bezafibrate. So I mentioned that it's a good drug for itch, and actually that figure is taken from a recent the Fitch trial, so fibrates and cholangiopathies. So I think Bezel will probably slot in the itch algorithm at about the same level as rifampicin, and actually if you've got biochemical abnormality, you'll get 2 for the price of 1. And I would just urge you to remember iron deficiency. So iron deficiency exacerbates itch, and particularly in our young, still menstruating females, actually, even if they're not anemic, give them some iron, it makes their itch better. So to conclude, ursodeoxycholic acid, it's a good drug, it's safe, it's cheap as chips, use it properly. So 13 to 15 milligrams per kilogram per day. And risk stratification, recognising high-risk people and referring them, or at least discussing them with a specialist unit. And PBC comes with a significant symptom burden. We can manage itch, and we should, and there are lots of drugs, and if you're not sure how to manage it, send them to somebody like me who spends a lot of time talking about itch. Fatigue and cognition remain really challenging, and we have no effective treatment, and transplant does not improve fatigue. So we mustn't set people's expectations too high in terms of that. And second-line therapies are now available. We don't have long-term outcome or histology data from RCTs, and we do, at the moment, we lack a direct head-to-head trial of obeticholic acid versus bezafibrate. And I would just, there is this concept of missing the opportunity for transplant. So if we're giving second-line therapies, we should always be thinking the transplant question as well. So I'm happy to take any easy questions.
Okay, thanks very much, Jess. I think, unfortunately, we've run out of time now.